So now let's move on to the next exciting event of the day. May I request Dr. Amok Shahane from Navi Mumbai IAP for most anticipated Dr. Vijay Yevle's endowment lecture. She will take the proceedings further. Dr. Amok.
Good afternoon, everyone. After today morning's fantastic scientific session, I'm sure all of us are looking forward to the much awaited endowment lecture. And it's a proud moment and a humble moment for us, for it is being conducted for the first time at Navi Embicon. To take the proceedings further, I call upon ex-Navi Mumbai IAP President and current Central IAB EB member, Dr. Jitendra Gawane on stage.
Good afternoon, everyone. It is my proud privilege to read this. Respected dignitaries of the dais and in the hall, today we have gathered here to honor a pediatrician who has dedicated his whole life to the health, happiness, and well-being of children. Caring for young lives requires not only clinical skills, but also boundless compassion, patience, and unwavering sense of duty. Dr. Vijay Yevle is the guardian of the well-being of the children of Navi Mumbai and India. Through his helping hand, he has shaped the foundation of bright futures for many of them. We thank you for your tireless work, dedication, extraordinary commitment for caring children over a long period. His vision and sensitization on rational antibiotic stewardship has impacted many pediatricians and practitioners about the future dangers of antibiotic resistance and has taught us their rational use in daily practice, not just in Maharashtra but across India and world. He has contributed immensely towards Central IAP, Maha IAP, Mumbai IAP and Navi Mumbai IAP, and has always been shouldered the responsibility of betterment of IAP at local, state and national level. Infectious diseases were your keen interest, and your work has inspired many youngsters to join the interesting field. Navi Mumbai IAP team is very happy to announce that from this year 2024 onwards, we are commencing with Dr. Vijay Yevle Endowment Lecture in our annual conference for your contribution and commitment towards Navi Mumbai IAP. We wish you all the best for a future endowment and healthy life ahead. Thank you, Team Navi Mumbai IAP. I request Dr. Satish to accompany sir on the stage. I request Satish to felicitate us, sir. Ladies and gentlemen, this year we are proud to announce the first Dr. Vijay Yevle Endowment Lecture to be bestowed upon none other than our immediate past President of Central IAP, Dr. Upendra Kinjavdekar, sir. Sir, please. Dr. Upendra sir doesn't need any introduction. I request sir to start with his endowment lecture and then we will proceed for the event. त्यांना चेंज दे, स्लाइड चेंज दे.
हॅलो, मला एक पाण्याची बाटली जरा ठेवा. So good afternoon, friends. At the outset, thank you so much, Team Navi Mumbai, and of course, Mumbai, this Navi MBCon. We have rekindled the MBCon, which we are successfully running for so many years. And for the first time, we are having Dr. V.N. Yevle Endowment Lecture. So what a proud moment for me personally. Everything has been talked about. Everybody here in the auditorium knows about Dr. Yevle. But the most important quality, of course, I have been his houseman when he was a registrar in Sion Hospital, and from that day till today, he's been my best friend, not only in pediatrics, but at a personal level also. And the most important quality which was not spoken is humility. Okay, so I get emotional when I talk about Vijay. Don't know which is apology and which is clap. Okay, so I thought of a topic which would be, involving, encompassing all the pediatricians and what way to go about it. So this is not working. It's चालू नहीं है? करा ना next. नहीं होते. तुम्ही तोपर्यंत हे बॅटरी चेंज करा, तोपर्यंत मी इथनं करतो. होईल? नाही. नाही? ठीक आहे, तुम्ही बघा, तोपर्यंत मी इथनं करतो. It's okay, I'll do it. Yeah, so we are pediatricians, and there are three things which are common to each one of us present over here in the auditorium. Can you guess us? What is number one? We are all pediatricians. Number two, we are all IAPians. And number three, what is the most important and commonest thing? Our index finger has this mark, each one of us sitting over here. So we have all just recently voted. So that was a connecting point. So we pediatricians, we felt that pediatrics is the best branch. In fact, to be honest, during my time, it was the number one branch. And everybody wanted to who topped in the, or maybe took the highest marks in medicine at that time, 3rd MBBS, because there was no NEET at that time, fortunately. So all of us had some passion. We had to develop certain skills depending on the branch that we chose. And then, of course, the most important common factor, love for children. And that is the one factor that most of us took pediatrics as the branch. Of course, not other subspecialties of medicine can talk about. None of the ophthalmologists doesn't say, I like eyes. Maybe to some point, gynecologists cannot say, and the anorectal surgeons just cannot say. Okay, but we love children and we are very proud of the fact. So is it so? Now still does it remain the number one branch? If you talk about the PGs, they must be talking about, I think dermat has taken over, so many other branches have taken over pediatrics as the number one. And then I thought, what is it? When I moved around last 2 years, all over the country, pediatricians are somehow now very happy. They said the parents are too demanding. Vaccination is taken over by government, so many vaccines, but then I do not have anything. Saturation in all cities. Where should I go and start practice? Corporate hospitals, and they just want onco, orthopedics, and whatnot, but they don't want pediatrics as the subspecialty. And the super specialty, is it really viable? Can I just call myself a super specialist and still can I practice, or still at the end of the day I have to see fever, cough, cold, give some vaccines to so I can survive? So many reasons for somebody not being very happy about pediatrics. And I said, what is happening world over? Let me just have a look at that and look at this, the changing scenario. The child health care is frequently regarded all over the world as secondary objective in the development of public health policies. To the extent, European Pediatric Association came out with this kind of paper that the demand of pediatricians in last 20 years in all over Europe has decreased. Cost containment is the priority rather than quality healthcare. And that becomes very difficult as far as pediatrics is considered. And WHO data, look at that. The average number of general pediatricians per 100,000 population has decreased by 30% in this 21st century itself from 1998 to 2013 from 26% to about 18.5. So point is, pediatrics is no more a very demanding branch. So pediatricians may not be happy. And then I came across this article, a few pediatricians as possible. Let's have very few pediatricians and as many pediatricians as necessity. And this is a joint publication of 16 pediatric societies all over Europe. So they all came together and published this paper. And what is the alternative that they said? They said train the GPs. So training the GPs would be the best thing. And what kind of courses are they contemplating? Do you know that there could be as short as 6 weeks course, there could be a 3-month course, there could be a 6-month course, and there could be a longest of 1-year course. So a branch of pediatrics being done by GPs by training for some couple of weeks, and they would be taking care of children. No, that's not a big deal. And that's not at all acceptable to us. So all of us sitting over here very well are aware of the importance of pediatric branch, but at the same time, let us understand. So what I'm going to discuss about is deciding certain priorities. So 2 kind of setups. We have OPD pediatricians, and we also have those who have their own nursing homes. They do admit children. Some are intensivists. They have ICUs. So these 2 places, what are my priorities as far as pediatric practice is considered, and how can I improve the quality of my practice? If I'm able to do both these things, I'm pretty sure that in coming years, we would not that today also we are all very proud pediatricians sitting over here, but the coming generations, they would never be discussing, oh, pediatrics, don't go for it. They would be proudly telling others, next generation also, yes, pediatrics is very important. So let's start off with neonatology. All of us, whatever said and done, are neonatologists and do take care of newborns. So 46% of maternal deaths, 40% of stillbirths, and 40% newborns are dying on first day of life. So that's a big focus areas that you and I need to put our efforts together. There is a transformational change in the process of this delivery system is needed. And though OBGYN have talked about the respectful maternity care, I think immediate and intrapartum, postpartum period is the focus areas where pediatricians really need to put in efforts so that this 40% comes down to single digit and maybe 0% in coming years. So which are the areas that I need to talk about? NRP, the flagship program of IAP, started in 2009. Now we are in 2024. More than 200,000 have been trained, but still at many places there is a need, and we know the asphyxia neonatal and its consequences. So we need to put in some efforts. Lactation management, friends, many of us who attend deliveries, we can say that 41 to 42% is immediate lactation. The early breastfeeding, 42% only. What can happen? So 58% of our mothers are not able to feed, or the babies are not able to get their birthright of early feeding. And that's a big area. I think 42% is a pathetic figure, and it has to come to 70, 80% as far as early lactation, early breastfeeding is considered in 1 hour. What prevents us? I just don't know. Small vulnerable newborn is a big thing, which 2023 Lancet came out with this paper. And the small babies, the early, the small for gestational baby age babies, the 2,500 and less birth weight babies, these are the 3 categories that they talked about. And all of us know that the preterm and SGA together are the worst to have it. And of course, only SGA have better chances, but preterms also are in between. So 3 focus areas, working on preterm, working on SGS, and the combined 55% of our neonatal deaths would be better off. Of course, OBGYN people, colleagues also come in place, but if I am at medical college or even at my own level, if I could pay attention to this small vulnerable newborn, I think the figures are going to be fantastic. Newborn screening, friends, at 1 year and 2 years and 5 years, I get a congenital hypothyroidism. That's a shameful thing, and none of us as pediatricians would be wanting to have such children. So what prevents us from doing this? Every baby that comes under care from birth has to have minimum newborn screening, and this is not at all acceptable. Developmental assessment time has come, especially high-risk newborns. Survival from 24 weeks, we just about, in the many talks that we are talking about 24, 26, 28 weekers surviving, but what happens to them once they go out in society? I think their developmental assessment periodic is so important. Samir is sitting there, I'm sure tomorrow he's going to talk about, but NCECD, the nurturing care, early childhood development principles, early interventions are so important. because that has given you a chance that your OPD practice can be expanded tremendously. Even if you concentrate only on NCECD practice, you would be very famous in your area. So these are the areas I felt that as neonatology, as a general pediatricians, even if I focus on these areas, that would be wonderful, and we must put our efforts into it. Going beyond neonatology, I felt these are the 5 key focus areas which pediatricians have to put in their efforts. The complementary feeding, the immunization, rational antibiotic practice, assessing the nutritional status, and of course, prevention of non-communicable disease. What makes me say so? All of us know, again, the figures speak louder. Let me just talk about complementary feeding. Very important phase wherein the health parameters are just going, our mortality rates, our underweight, our stunting, our wasting, everything. Exclusive breastfeeding is 63% in this country. Again, for up to 6 months, what I'm talking about. But complementary feeding, 55% of them, they do not get any message about it. What are we doing at 6-month visit? So that's very important that we must have. Look at the babies who are getting adequate diet. 89% of them do not get the minimum diversity and do not get micronutrients, and all problems start there. So 89% is not acceptable. Only 11% are getting in NFHS 5 data. And non-breastfed babies, unka to dono jagah se takleef hai. They are not getting breastfed also, and they are not being advised. So I think 6 months visit is extremely important. We must spend some little more time on that, and so that we tell them a little bit more about. And that gives you an additional advantage, because baby who has gone out for vaccines comes back at 6 months for flu shot, and we must make full utilization of that 6 months visit so that the mothers and the parents are aware of what they are supposed to do. झालं का? करतो? काय रे? नसेल होत तर जाऊ दे, ठीक आहे, चुके, काय हरकत नाही. Okay, immunization, we have already talked about. We are not 1, not 2, but 3 sessions. And we discussed threadbare about these different vaccines. We know pediatricians are doing much better than general pediatricians. But let me tell you, make you aware of the percentage of babies getting these vaccines. The hepatitis A, typhoid, varicella, Japanese B, Tdap, annual flu shots, HPV, and MMR. Do you know that number of pediatricians, IAP members, we talk about 50,000 today, we heard the figure, we are reaching 50,000. It's not even 17 to 18,000 of pediatricians who are recommending these vaccines. The number of the outreach of these vaccine companies is maximum 14, 18 to max 20,000. So what are the rest of the 30,000 pediatricians? So forget general practitioners, forget everybody else. We pediatricians ourselves, we just discuss about 1 dose of typhoid or 2 doses of typhoid, but at least start giving. We are not doing that. What prevents us that from after MR 4 weeks come and give MMR? I just don't know. So let's all put more efforts in these vaccines, because every vaccine we just heard discussed that it's important as far as preventive strategies considered. After breastfeeding, this is the second most important cost-effective interventions. Talking about the third, rational antibiotic practice. Dr. Yevle sir is sitting over here, who gave us a program of rational antibiotic practice, avoid antibiotic abuse, and we must know that stewardship is required not only in OPD, but also in IPD. First and most ideal would be if your own hospital has its own protocol. Yes, definitely have that resistance pattern. You know about sensitivity, and then please go ahead about it. If not, at least follow these guidelines. And Indian Academy of Pediatrics has it. American Academy of Infectious Diseases, they have it. Start following something, but keep following. And the best document, thank you Jitu for sharing this. I just came across this. This is a brilliant document. You have to read every word of it, and done by our own government of India, the National Action Plan on Antimicrobial Resistance. It teaches you from susceptibility to common antibiotics, what to use, what not to use. A brilliant 2024 document. Must go and start using, implementing every word of it in your day-to-day practice. And then finally, 2 things, assessing nutritional status. We have been talking about, Ambedkar sir always talked about growth chart. If a pediatrician is not plotting a growth chart, he's not a pediatrician. That's a statement that sir has made from this platform so many times. Time has come, we have to have our own, we have IAP charts, start following it. But there was one lacuna wherein IAP charts do not help us, the WHO charts do not help us, but Intergrowth 21. Most of us have newborn practice, and wherein the newborns are surviving. I had yesterday a 29-weeker delivery happening in my hospital. And then we had to use this intergrowth chart. Brilliant charts. I'll tell you one single advantage of intergrowth, that it is not only from 24 weeks. So as early as that, you can follow them up. And they tell us that some babies, otherwise if you start putting them on Fenton chart, WHO of course doesn't talk about preterm chart, they would be falling down, and you would be tempted to use a market substitute, breast milk substitute, which would be completely avoided if you start plotting on intergrowth 21. So start using for all your preterm babies, start using the intergrowth 21 chart. And of course, last I felt that every pediatricians now, time has come, we should be aware of the prevention of NCDs. We did Sankalp Sampurna Swasthya, we are continuing and will continue it as long as everybody is committed to it. But let me just share a couple of figures which will make you understand how important it is, what is the current prevalence there. So blood pressure, look at this, what is happening to our children from 10 to 12 and 12 to 19 years of them. Prevalence of high BP is 35% in children from 10 to 12 years of age, 25% in those 13 years and above. And this is published in JAMA, Dr. H.P.S. Sesde, one of the authors. So figures are really phenomenal, and we have to start working on it. We had not heard of such kind of figures earlier. Prevention, substance abuse, look at this, 1.58 crore of our adolescents have not only just tested, but they're addicted to substance abuse. This is 10 to 17-year-old, and this is an official figure given in Supreme Court by the government of India. So this is, and finally, talking about type 2 diabetes. Did we hear of it when in our residency? How much was the prevalence? And now today, India is second only to China. 400 type 2 diabetics in adolescent in upper 100,000 population. So huge increase, and all this is related to consumption of ultra-processed food, the changing lifestyles. So prevention of NCDs, otherwise all of us know that even we are susceptible and have some sort of challenges because of changing lifestyle. So let's all work on that and try to have more of prevention of non-communicable diseases. Obesity, the final thing, 13% are overweight, 8 to 9% are obese. We are going to have 17 million our adolescents above, and everybody is working on that prevention of that obese children by 2025. 50% of those are going to be obese adults. And you know what American Academy is concentrating on? They are only talking about anti-obesity drugs, how we can expand indications of bariatric surgery. We in India just cannot afford to do that. We have prevention as the best policy as far as that is considered. And finally, mental health. Look at that, 1 in 7 of my adolescent is suffering from some mental health issues, either depression, behavioral problem, anxiety, psychological distress, internet addiction. Who will look after that? So we'll have to put in some efforts over there if we have to have better adolescents and productive young adults. Now let's move from OPD to wards. Many of us not only have OPD, we have our own nursing homes. We do take care of them, give some medications, and of course patients are being taken care of in such situations. So what are the things that you and I can do in day-to-day practice when we are really talking about these children? I come from LTMMC. My respectful gratitude to all my teachers over there. And what has happened in that, when I joined there in the year 1986 as pediatric resident, we had a PICU on one side and NICU on the other side. One was headed by Dr. M.N. Mehta and another was Armida Fernandez. And at the junction, there was a board which was written this, a story of 4 children. I still remember this was a very important board. A job was to be done. Anybody could have done it. Everybody thought that somebody will do it, but nobody did it. So this is a very, very, very common. The moment we are into such kind of setup where are people working with us, where it could be a small nursing home or you could be a corporate hospital, assigning job responsibilities so important, and unless and until we do that, there are going to be mishaps. And now rest all over the world, people are talking about quality and safety. Safety, do no harm, is the first thing that we learned about it. But improving quality, the world is talking about that. What is it? Basically, efficient, effective care, purposeful action, doing things well, and raising the ceiling of overall care experience for the patient is better one. Of course, that cannot come without safety. So no harm, avoid bad events, less likely the mistakes are going to happen. So we need to understand the quality is important, the safety is the standard, and both these things come together hand in hand. So avoidable medical errors, we must and the number of errors that are happening are tremendous. All of us know that the more number of days the patient is in hospital. So can we prevent it? Can we minimize it? And how can we do it? So checklist. All of you must have read the book by Atul Gawande, Checklist Manifesto. It was all, inspired by this. The flight, when it takes off, the pilots have to do certain things, 1, 2, 3, 4, 5, 6, 7, 8, because there was a, Boeing accident and following which this has happened. And then after this checklist, the number of accidents have gone down. So Atul Gawande proposed certain things before any surgery, or just start talking. Patient's name, this. Surgery indication, this. This is done. This is done. So keep checking. So read and do. At least read and do it, or do and confirm. If you're an experienced one, you can do and confirm. But you're a beginner one, somebody, it has to be ticked. Very important. There is a cartoon there, but because of the video, you are not able to see that. So I think very important to have a checklist, because a simple checklist, they have said, in 8 African countries, they started using checklists before some simple abdominal surgeries. And you know the difference, 36% of complications reduced and 46% improvement in mortality. So just by checklist, very important that done this is what is important, confirm and do, or do and confirm. Right things, right dose, right time, right patient. All of us know, looks like a Ghisapita sentence, but so important when you do it in the dose calculation here, legible handwriting, avoiding trailing 0. We need not write 1.0, whereas we have to write 0.1. That can completely change the picture if the nurse is not able to read it. Label syringe, Lhasa, look alike, sound alike. I don't know how many of you are aware of the case which happened in Thana. After circumcision, the child vomited, and it was asked by the sister to give perinom, but instead of that, the patient was given fentanyl. So imagine what must have happened to that patient. Instead of perinom, the child succumbed after circumcision surgery by sound-alike, look-alike medications. Not one, but both brothers. Those who are from Thana would definitely remember this happened way back in 1991. But communication is another skill. I'll just talk about it. But very important to understand that, again, because of video, you cannot see that. We are all shy to refer to something because we feel, all the lawyers, when they have certain challenges, they immediately go back, see the book in front of patient, their client, and they go. But we feel, oh, no, I should know everything. Need not be. A patient may come to you of that particular condition after many years. So there is no point in feeling shy about referring something rather than committing mistakes. And finally, I think a group can only work if medical staff members should speak up independent of their rank and role. The junior most person in your system, if he or she is allowed to speak, sir, I feel this is wrong, sir, I feel this has already been done, sir, I feel this is something not good with this patient, then, hey, tum chup baitho, main bol raha hu, I am the chief. No, you cannot do that. So let's allow the junior most person to also share their observations. Mind you, they are there with the patient more amount of time rather than you and I are spending. And this is about the legible handwriting. I said a KCL or Act Rapid 4 units or 44 units, and what could happen to that, So let's all be, there are marks for guessing what kind of medicine is this. So let's be more legible in our handwriting. Hand hygiene, nosocomial infections, we talked about SARS-CoV-2 and we know about hand washing. But do you know that respiratory syncytial virus, RSV, that also we discussed. It's much faster spreading kind of infection that we have, bronchiolitis baby, and after that going to another baby, we have to wash our hands with something. That's so important, and unless and until we do that, this is not going to. So I think we have to prevent. There was a beautiful article presented by Nair Hospital where they said 27% nosocomial infections in pediatric ICU. That's huge amount, and we must take care of this nosocomial infection because patient has come for something else and goes back with something else is not done, not acceptable at all. Protocols, importance of this. The sepsis protocols, we had it from 1991 to 2011. So many protocols, but they were not used. I'll share with you what happened in America and how sepsis protocols. There was a boy which was admitted, adolescent boy, went to a general practitioner, then was referred to a higher center, and somebody missed sepsis in that child, and ultimately child went into decompensated septic shock and succumbed. And then the investigation started. It was known that probably when the child was in early sepsis, this should have picked up. Then there was a big uproar in the parliament, the legislative assembly there, and they said, why don't you have a sepsis protocol? This I'm talking about 2013 in New York City. And then doctors said, oh, who are you? Like everywhere, how can the MLAs and MPs tell us to make protocols? But ultimately, they had to go down and they had to make a protocol. And afterwards, there is history that sepsis outcomes in New York and everywhere. So unless and until we have a protocol in place, we are not going to have great figures. And let's use them as much as possible where there are standard protocols available in system. So paradigm shift, I think another thing which is happening, our care, I felt, is only doctor, nurse and paramedic centered, and we are not giving much attention to child and parents. So मैं boss हूँ, मैं बताता हूँ, मुझे इसके बारे में मालूम है, so try to follow that. The time has come that we have to change our focus and disease should be centered and all of us need to act, the child, the healthcare provider and parent, and we have to target the disease rather than showing that upmanship of us. So I think involving parents in day-to-day consultation is so important. So shared decision making is a new thing which has come and which must be used. I'll give you an example what is shared decision making. We have a patient of ITP, a newly fresh diagnosed ITP, otherwise fine. We know when he's diagnosed and no high risk indication, risk of bleeding. We have couple of protocols and standard therapies which are allowed. You may give steroid, you may give IVIG, and there is something called as watchful waiting, which is a standard recommendation by all over the world, all medical authorities. We have to give these options to the patient, and then in consultation, if the patient feels, I want to go for watchful waiting, but you are the one who always wants a steroid or IVIG, I think both need to consider. It could be other way around, that you would be the one who would want a watchful waiting, but the patient could be the one, no, Dr. Saab, give something. The point is, involve in the final decision making. So this is coming in a big way. Rest of the world is talking about shared decision making. So let's not take entire responsibility on us. But once we are committed, don't say, मैंने तो ऐसा बोला था, तुमने तो ये choose किया. That cannot be done. We have to stand with our patient and their families. So this is another thing which everywhere, all over the world, discussions are happening, whether the parents should be allowed to be in the procedure. From small IV to LP, I don't know what about tracheostomy or intubation, whether they should be allowed. In our hospital, all, LSCS, not only for delivery, but LSCS also, the father is allowed to be there, completely present. So physician has to explain, should know that there could be, layman may not be able to stand for the blood, but it can happen, they can also faint. But the point is, we have to give the choice and the presence, in fact, child feels better. And instead of feeling apprehension, what is happening behind the curtains, probably the parents would be much more cooperative when we are dealing with their day-to-day work. I think communication is lesser said or more said. I think we have to have, this is one skill which was not taught to us in our UG PG days, and we have to learn. For a successful practitioner, a communication skill is the most. You may not have read so many papers, but if you are very good communicating with the patient, I'm sure you have done half of the things. So let's have hearing is passing, all of us know, because the ears are open unless and until you put something there, you're going to hear. But the listening is active, your correct body language, understanding the body language of the patient sitting in front of you. Because why is it so important? Because lack of communication equivalent to medical negligence. All the cases that happen of medical negligence, majority of them are because of our lack of communication. We had a brilliant module last year, thanks to Rajesh Chokhani, who had done the communication skill. A brilliant module. We did not do much program, but please, let's have a complete program only on communication skills from UGs to senior practitioners, and that would go a long way in your successful practice. And finally, I would like to say that one important thing, that you should feel proud. If you have lost one child under your care and still the parents come to you with second child, you have done it. That means you have been a successful practitioner. If we do it badly, the patients or family members may never forgive us. If we do well, they will never forget us. And that's the biggest pat on your back, that if in spite of knowing that earlier child was lost under care of this doctor, still they feel doctor had done everything possible best, you should feel proud at the end of the day that you were able to help that family. And of course, one thing that anywhere, pediatrics, why we said we love children, patient under care, admitted somewhere, we have to talk. A human touch is important so much. Doesn't take any extra time. Just speak to children, those who are admitted under you. Talk about their school. Even in OPD, have you ever talked about which school? We have to have certain other kind of communication, their interests, stories related to their hobbies, who had come to visit them, referring by their name rather than page number 37 ka kya ho gaya. Let's remember, try to put in more efforts in remembering names. Patients just love it. And this human touch is very important. The most important, abuse can be neglect. If I come into the hall and none of you recognize my presence, I feel at this age also I may feel, oh, neglected, some kind of abuse. What would happen to that young child? So let's recognize their presence. That wonderful, cheerful smile, irrespective of their condition, would go a long way. And final, I think this is going to be in upcoming years, we are going to have more stories of ethics, legality, and morality. Right now, medical science does not have clear answers to it. Like this girl was hit by falling branch in Bangalore. She was sitting behind her father and a falling tree branch, and she, 701 days, she was in coma. So people were discussing, is it worth? And then ultimately the treatment was stopped. And more importantly, entire Europe was talking about Elfie Evans. So this child had a neurodegenerative disorder. First 6 months went wonderful, had a neurodegeneration. Finally, to the extent, then ultimately it was GABA transaminase deficiency. The brain was nothing but CSF. There was only CSF, and the child was just put on life-saving measures. The complete, of course, in UK, you know that entire system, the money is paid by the government, and that's why that government said, this is inhuman, insensitive, let's stop, because this child is not going to make it. But the parents said, no, we want to take this, please continue. Otherwise, Italian government said, no, airlift the child to us, and as long as he is alive, we are going to support this child. But this kind of things, I think we do not have clear answers, and they are going to come more. With AI coming in, more and more of legality, ethics, and morality will be there, and pediatricians will have to answer certain things. Final word about you and I. We are putting so much effort, spending so much time in our work. Friends, healthcare is the only industry that does not believe in fatigue, diminishing our performance. Look at this, long working hours does not increase our output. Pure myth, because our lower productivity, worsening performance, unhappy doctors. So let's have a balance of everything, put in more efforts, but at the same time, let's have some time for ourselves also. Economic data from 1990 to 2012, human brain cannot concentrate for more than 8 hours. Germans work 600 hours less as compared to Greeks, but the productivity is 70% higher. All of us know that. And really, ideally, 52 minutes workout and 17 minutes break. You can go to Google and just type 52 minutes versus 17 minutes, and there are wonderful, great articles on that. It is considered 52 minutes complete concentration of the work. That time, no WhatsApping, no Facebooking, not even looking out of window, but in 17 minutes, nothing of the official work. So 50 to 17 is supposed to be, it can increase our productivity. So let's all try to work smarter than harder. And I would just like to end that if we put in all these principles together, and we have our great teams which are built together, which are completely not only passionate, but having compassion towards childcare, I'm sure that life is going to enrich us not only by giving so much that we have received, the bouquets from patients, but also we are going to enrich ourselves and of course make our community a better place, and it's going to be a rewarding experience, and each one of us at the end of our life will always be a proud pediatrician rather than a nagging pediatrician. So wishing best of everything to each one of you. Let's be happy about that. Thank you so much.
You've kept the audience spellbound and mesmerized as usual with your brilliant oratorial skills. I would now like to proudly present the citation on our beloved Dr. Upendra Kinjwadekar, sir. And I quote, so please sit down. You need to hear this. Upendra, the name denotes the younger brother of Lord Indra, a dwarf avatar of Lord Vishnu in Vaman Avatara, who was born to kill the ego of Maharaja Bali with only 3 of his footsteps. The charismatic features of Dr. Upendra are enumerated as follows: always energetic with a positive attitude, a very talented speaker and orator. Age is only a number for him, and his passion for the upliftment of child health is the key to many of his success stories. Ladies and gentlemen, Dr. Upendra has not only provided care to countless children, but has reshaped their lives too. Through his groundbreaking research and compassionate care and relentless dedication, he has addressed the most pressing issue affecting children's health today, and that is malnutrition. That is nutrition, both mal as well as O nutrition, through his innovative SSS with his Sankalpa Sampurna Swasthya program. He has developed a preventive strategy, educating parents and the community at large His work has left a long-lasting impact on children's health nationwide. Dr. Upendra reminds us of what is possible when vision meets compassion. He also reminds us that children's health is not simply treating illnesses, but it's about nourishing potential and protecting their future and advocating a better world for them. So today, we, Navi Mumbai IAP, are happy to honor this remarkable individual for his contribution in pediatric health by awarding him with the Dr. Vijay Yavle Endowment Lecture for the year 2024. We wish you all the best for your future success and endeavors. Thank you, Team Navi Mumbai IAP. I would now kindly request Dr. Yavle sir to felicitate Dr. Upendra with the shawl and Shrifal. Dr. Upendra to felicitate sir with the memento. Dr. Ditendra sir. And Dr. Satish to felicitate with the citation. And Dr. Amit with the hamper. I would now request Dr. Amit to give the vote of thanks.
That was an excellent lecture. Thank you, sir. And on behalf of NMAP, I would like to thank Dr. Vijay Yavle for his immense contributions to the field of pediatrics and bringing Navi Mumbai prominently in the national map. We are proud and honored to have the endowment lecture starting this year in your name. I would like to congratulate and thank Dr. Upendra Kinjavadekar sir for gracefully accepting the honor. I would also like to thank our very own Dr. Prashant Moralwar sir, the founder president of Navi Mumbai IAP, who sowed the seed with just 3 people as a branch members, and now it has grown to a branch which is so big. I would also like to acknowledge the presence of Dr. Dorab Daruwala sir, Dr. Praveen Modi sir, and Dr. Shilpa Araskar sir, madam, who are the past presidents of our branches. I would also like to thank our very own CIP member and also the past president, Dr. Jitendra Gawane, in guiding us throughout. And lastly, all members of Team Navi Mumbai Academy of Pediatrics and the Team Mumbai Academy of Pediatrics for working tirelessly to make this event a grand success and this joint alliance a great program. Thank you so much.
We'll just take 5 minutes to appreciate and felicitate the judges of the poster committee. And I invite Dr. Sushma to kindly call them on stage.
May I request Mamta Manglani madam to come on the stage, please? Dr. Vijay Kamale sir and Dr. Meenaj Sheikh sir.
Thanks to the scientific committee for the posters and all the judges. Our body moves perfectly well in symphony due to our hormones. What happens when our own Beethoven and Mozarts go out of a sync? That's the topic of our next panel discussion, hormonal disharmony. May I invite to moderate the session Dr. Amruta Shirodkar, Treasurer IAP Mumbai since 2021, a very well organized and having a great eye for perfection, attached to Nanavati Hospital and Guru Nanak Hospital and Surya Hospitals. Dr. Amruta Shirodkar, along with the eminent panelist, Dr. Sudha Rao ma'am. Ma'am does not need any introduction. Academically very highly accomplished. Ma'am is HOD of Chief Division of Pediatric Endocrinologist at Wadia Hospital. With her, Dr. Alok Sardesai, very diligent and committed pediatric endocrinologist attached to Hinduja Hospital, KDA Hospital, Navi Mumbai and MMR Hospital, Thane. With Dr. Prashant Patil, very proficient and adept endocrinologist and diabetologist attached to Apollo Hospital, Navi Mumbai and SRCC Hospital. May I welcome everybody on the stage to continue with the next panel discussion. Thank you.
नहीं hormonal disharmony 7 number. A very good afternoon to all the delegates, respected faculty, seniors and my dear friends. So now we shall start our panel on endocrine disorders, aptly titled as hormonal disharmony. We know when the hormones are not in harmony, a lot of chaos can happen. So thankfully today, to guide us through this roller coaster, we have an expert panelist with us who will help us delve into the insights of common endocrinology scenarios which we see as general pediatricians. So without wasting much time, we will now start with some common case scenarios which we see in our day-to-day pediatric practice. So to begin with, we have our first case. This baby is at day 45 of life, now presenting with yellowish discoloration of the eyes and the skin. There are feeding problems that the baby needs to be awakened many times to feed. On examination, there is a poor muscle tone, umbilical hernia, large tongue and jaundice. Birth history-wise, it was a full-term section delivery with slightly LGA baby weighing 3.7 kgs, cried immediately after birth. There was no significant perinatal events. Now when the baby presented at 1.5 months of life, we did a TSH, looking at all the symptomatology. And very unfortunately for the child, the TSH is 130 and the T4 is 3.2. So, Madam Sudha Rao, we know that we are dealing with congenital hypothyroidism. So I just want you to share your insights on screening of congenital hypothyroidism, whom to screen, when to screen, and how to screen.
Yeah, thank you. Whom to screen? There's nobody who should be left out for screening. It's a birthright of every newborn to get a newborn screening. So all neonates,
Absolutely.
whether preterm, whether full term, have to be screened. Yeah. When to screen? So that depends on the logistics and the program that is followed by the institute or the hospital or the nursing home. So you can screen at 2 time points, especially in relation to hypothyroidism. Either you could do a cord blood screen, which is logistically easy. You will not miss out any child from the screening point of view. Or you could do a day 3 screen, which will be a heel prick screen that has the advantage of being able to screen for other disorders also, as the whole spectrum of newborn screening.
Right.
So, yeah. And then how to screen? Okay, that's the same answer. Yeah.
Yeah, so for ma'am preterms, the recommendations are slightly different. We don't do cord blood, I believe. And we,
Given the amount of heterogeneity in terms of care of preterm babies, of course, if you have a 28-weeker, 750 grammer, the priority there is to ventilate and give him a proper newborn care, as compared to someone who's, say, born at 36 weeks and has a weight of, say, 2.5, will not need an NICU kind of an admission. That baby has to be screened. So if you bring in the heterogeneity, there might be omissions. So it is better to screen even preterm babies, especially by day 7 of life,
right.
if they are sick.
Right, ma'am. How to screen, I think we all know, it's either a filter paper or a serum screen by a venous prick. So, ma'am, what to screen, madam has already said, TSH. Ma'am, what is a positive screen? When do we say that this is a positive screen now?
So when you run a screening program, any TSH which is more than 20 is screen positive. That means we need to look at these babies again, call them back and see whether they are having a thyroid disturbance. Anybody between more than 34, this is as per the Indian Society of Pediatrics and Adolescent Endocrinology guidelines. You need to screen, not wait for 7 days, not wait for 5 days, maybe redo the screening as at the earliest possible. Meaning retest them at the earliest possible. And there is one more category where you have even higher TSH, where the cutoff is 40, where you may start even the treatment before checking the baby so that you don't waste a long period of time.
Right, ma'am. So this was about the screening. If the screen is come positive, as madam rightly said, about 20 or more than 34 at 24 to 48 hours, do we need to confirm it? How do we confirm and what do we retest now when we confirm?
So your screen positive is only an indication that this baby may have underlying congenital hypothyroidism. So you would confirm by doing a full panel of tests, which is the total T3, total T4, TSH, or if you have the facility, free T3, free T4, TSH, or just T4 and TSH is also enough. Having said that, breaking our, meaning it's like discussing a lot about what components to be sent has a meaning when you're funding or you're able to do the test on your own. If the cost is not much different, it's okay to do the whole of it,
panel.
T4 and TSH.
Right. Right. So when we retest, we have to send the whole panel. It's not just the TSH. This is important. We need to send the free T4 or the T4, also a T3 and the TSH. Now from whom and when to start treatment? We have confirmed this is hypothyroidism. From whom should we start treatment and when to start treatment, madam?
For whom? Those who are screen positive and then you've checked again and they fall in the category of congenital hypothyroidism, you have to start treatment. Now what is that abnormal retesting? Is when you have a low free T4 and a high TSH, you're going to call this as primary hypothyroidism. These children need treatment. But you may also have a scenario where the free T4 may be very low, okay, and a normal TSH. This speaks of something like a central hypothyroidism. This baby also needs to be started on treatment. Or you may have something in the compensatory variety where the TSH is high, but the T4 and free T4 may be in the normal range, upper normal or low normal kind of a range, where you would want to start treatment. When to start treatment? As soon as you suspect treating, meaning over treating and treating on the suspicion is a bit better than not treating and saying I'm going to call you after 2-3 weeks. Preferably the same consult, you should start the treatment.
Right. So important take home here is I think that we don't wait for etiological diagnosis. We know it's a congenital hypothyroidism and we should start treatment as soon as we make the diagnosis. What dose? So
it's
it's written. Yeah, but I just want to know, ma'am, how do we give levothyroxine?
So just a anecdotal take-home message is, suppose you don't have a weighing possibility at that time. So any neonate will normally need 25 micrograms to 37.5 micrograms. So when you get the strengths of each as the formulation. So normally children need 25 micrograms, babies need 25 micrograms. Some of them might need 37.5 microgram, which could be but if you say go by weight and you have coming out as 20 micrograms. So that weight criteria is for initiation and hence there is a range. So you may give 25 to 37.5 microgram at initiation of the dose. Yeah.
How do we administrate, madam, levothyroxine?
Yeah, ideally, this is best absorbed empty stomach in the presence of gastric acidity or whatever. So you need to give in a neonate, there is no empty stomach kind of a concept, but to make it into a proper habit, we try to tell the mother to or the parents to give it early morning pre-feed. Preferably have a gap of at least 3 hours between the 2 feeds and give the dose in the morning, crushed nicely and then mixed with the express breast milk until 6 months, and then of course it can be mixed in water. It's preferable in water than breast milk, but yes, initial few months we'll need to give it in milk.
And a few precautions which we need to tell the parents that concurrently they should not administer
Yeah.
any iron, calcium, any soya or laxatives and antacids. This is very important. Concurrent administration of this is not recommended when we are giving levothyroxine.
Yes.
So madam, now we have started treatment. How do we follow up these neonates and when do we retest now to see the treatment effectiveness?
There are guidelines available, but as soon as you treat, the target is to normalize the T4 within 2 weeks of starting your treatment. So you would want to check your free T4 at least in 2 weeks' time. After that, you could check it's given this protocol at 4 weeks. In the first 3 years, we do it every 3 monthly. Subsequently, it becomes 6 monthly till they are in the pre-adolescent age group. Again, during the pubertal age group, it's a bit more frequent. That's 3 to 6 monthly. Whenever there is a change in dose of thyroxine, you need to recheck in 8 weeks' time that whether the change is correct or not.
Right.
Yeah, that would be. But yeah, like you correctly pointed out, it's not only about testing. You'll also be looking at the anthropometry, gaining of milestones, and other things as
Right.
part of your follow-up. Yeah.
Right. So it's clinically and a lab follow-up which we do. And if many times the hypothyroidism may be transient nature, so when do we reevaluate, madam, to see if it is transient?
So yeah, if there has been a starting of treatment, you would like to check that again by 3 years of age. The magic 3 years is essentially because it's assumed that the brain growth, myelination, everything is complete around that
Right.
point of time.
Right. Okay, so now what is the role of additional testing, Dr. Prashant, in a patient whom we have diagnosed as congenital hypothyroidism?
So primarily the imaging is always a secondary choice. It is to
Right.
find out the etiology of the congenital hypothyroidism. So whether the question is when to start, whether to start, yes or no, that depends on your screening performance of a TSH. But how long do we need to treat, that is generally given by the imaging. So
Right.
thyroid imaging, sonography is the best investigation, easier to perform. Technetium scan, theoretically speaking, you should do before starting the treatment. Having said that, it depends on the isotope availability,
Right.
and there are very few centers who can perform the technetium scan.
Right.
The only advantage of the technetium scan over the USG would be to diagnose a ectopic thyroid gland and
Right.
the confirmation of thyroid aplasia. As far as thyroid autoantibodies are concerned, I don't think it is required for the congenital hypothyroidism. Serum thyroglobulin concentration, we don't do it practically because it's commercially not viable.
Right.
Thyroglobulin tells us about the functional thyroid tissue. So if it is athyrosis, your thyroglobulin will be extremely low. Whereas if you have a goiter, ectopic tissue, or dysharmonogenesis with big goiter, then your thyroglobulin concentrations will be on the higher side.
Right.
Urinary iodate concentration we don't do commercially.
Not
It is for the epidemiological purpose for the government to decide whether we need any additional measures to increase the iodine concentration. And
Genetic
genetic
studies?
studies, a bit controversial. Genetic is coming in big way. But again, even the AAP guidelines of 2023 clearly highlights that, if your genetic testing is changing the decision, it is helping you in clinical clinical adjustment of your treatment, then only you do it. So there are certain genes which is involved in thyroid dyshomogenesis and as well as thyroid dysgenesis,
Right.
like PAX8, DOX1, DOX2. So in that scenario, you can test it. If at
Okay.
all, precisely when you have symptoms which are dysmorphic, whether he is having congenital, congenital heart disease, or if there is a deafness and you're suspecting pendred, maybe you can do it. Or
Right.
if it is associated with central hypothyroidism and other symptoms, maybe then you can do it. But again, it all depends, how financially viable the
Right.
patient is.
Right. Okay, so that was good. Just two questions. Any false negatives with this neonatal screening, and does the level of TSH predict the severity of the defect? Dr. Prashant.
Yeah, so all your NICU graduate, I think preterm, sick infant, your monozygotic twin, a peculiar condition that is trisomy 21, they all are associated with a delayed TSH rise, which can be missed if you're doing a particular test, precisely if you're doing the TSH screening before 34 or 32 weeks. So ideally in that scenario, the second screening has to be done before the age of 36 weeks of completed gestation. So the second screening is required in those scenario. And does the level of TSH predict severity of defect? Yes, absolutely it does.
Right.
Higher the levels, more likely to have a brain impairment, more so when you're not treating the individual child within 2 to 3 weeks of a postnatal life.
Right. Thank you. Okay, so moving on, we have a second case. Now, this is a full-term normal delivery. The child has no significant parental history. A cord blood TSH was done at birth, which was 4.9. Now, at 3 months, we have this patient presenting with constipation, grotesque features, no social smile. Looking at all these features, a TFT was repeated. Now, TSH is still normal at 4.1, but the T4 is 3.1, and the repeat free T4 which was done is 0.49, which is low. Dr. Alok, your thoughts on this?
So I would call this a missed call, isn't it? So while we are happy that everybody is obsessed after doing a TSH, which we encourage at birth, but please do not forget a T4 or a free T4, because logically speaking, that is what is going to protect your child's brain. Also, because we are dealing with central hypothyroidism, do not forget that we're dealing with the hypothalamo-pituitary axis, and when one of the hormones is deficient, always screen for others. You could be dealing with multiple pituitary hormone deficiencies, especially in a setting where there is adrenal involvement. You would want to replace the adrenal axis first, and then go ahead and treat your hypothyroidism, because if you don't do it, you might precipitate adrenal insufficiency, because your thyroxine is going to metabolize whatever cortisol is there and is going to deplete it.
Absolutely, absolutely. So this is congenital central hypothyroidism, and since it is a central hypothyroidism, ruling out other endocrine deficiencies also becomes important. This child was put on thyroxine replacement after a pituitary screen, and the same child looking at 3 months now, much better.
You would have wanted this smile at 2 months.
Absolutely. I mean, it's really unfortunate that both the babies were not picked up at birth. And I think Dr. Upendra also stressed in his oration about neonatal screening, and this is all something which we all must vigorously follow.
He also mentioned something called as checklist, like
Yes.
a pilot does. So follow protocols like you follow a checklist. It will help you with preventing these missed calls. You don't like missed calls. Not necessarily. Not necessarily. It is inappropriately normal. Even if it was 7, 8, 9, I would have still called it.
So actually it is misleading. I mean, you just see the TSH, you can get misled. So the need to do a complete thyroid panel. Okay, we move on to our third case now. This is a 7.5-year-old girl born of a non-consanguineous marriage. She has breast development since 6 to 9 months. She has pubic hair development since 3 months, axillary hair development since 6 months. Now on inquiry, she is one of the tallest in her class. There has been a sudden gain in weight as well as height. She is irritable. There is increased body odor. There is no history of any headache or any difficulty in vision. The birth weight is 3.2 kgs. Dr. Prashant, should we evaluate firstly?
We have to evaluate this girl because any breast development before 8 years of age
Absolutely.
needs an evaluation.
Right. Now, can from the history and the examination, is the cause central, peripheral?
Most likely it is central because the normal sequence of puberty is maintained, like
Right.
Theralke followed by pubarche.
Right.
Menarche is yet to come, so probably it's a central than a peripheral one.
Yes. And excess androgen also, whenever it is a isosexual, it most likely is a central
Most
precocious
likely it's a
puberty.
central.
Right.
So excess estrogen rather than androgen.
Absolutely.
Excessive androgen will present as a isolated adrenarche or
Right.
something like that.
And
That's a
maybe
peripheral
more in
precocious.
favor of a peripheral cause
Yes,
as well.
Yes, yes.
Right.
And it will be very sudden in onset.
Right. So we have this patient who's presenting with a central precocious puberty because the pattern of pubertal development is maintained with a estrogen excess. Now, quickly, Dr. Prashant, on medical history, physical examination, what do you want to know?
So medical history, once they give the history of breast development, one need to ask whether there was associated growth spurt. That's the most important one. If you are finding on previous growth chart, there's a jump of 2 percentile lines that indicate that there is a abnormal growth spurt. Then birth weight, that is very important
Right.
because you're premature, tend to develop early puberty as well. CNS symptoms, that's most important for the central cause. Any history of drug, cranial irradiation to rule out central precocious puberty. On physical examination, obviously the SMR staging
Right.
is most important. Certain syndromes, so presence of cafe-olate spot, history of fractures, that is important.
Right.
Pubertal staging, absolutely, it is must. And every child, as per IAP guidelines also, who is beyond 6 to 7 years of age, depending upon girl or boy, you're supposed to do the SMR staging. Most important investigation is bone age. So X-ray of the left hand and wrist till terminal phalanges APV is what something that you will ask for.
Absolutely. So now we think we are dealing with a central precocious puberty. I just want you to tell me briefly, labs wise, what are the hormonal evaluation that you will do for her?
If I have only one choice, the basal LH, that's the most important and a sensitive marker for precocious puberty. Any LH basal value, which is beyond 0.3 or 0.4 milli international unit, indicates just about the onset of puberty. And the important thing is the hormonal changes or the blood changes always precede your physical changes by almost 1 year. So simple
Right.
LH is good enough. Apart from LH, FSH, estradiol I will do. Always rule out a hypothyroidism
Absolutely.
to rule out precocious puberty. And then in those borderline cases, we perform GnRH stimulation test.
Okay, all right. Any role to do adrenal steroid testing here, STG here? No.
No, unless we are dealing with the peripheral precocious puberty, then yes.
Right. Need to look for a USG pelvis?
Absolutely. USG pelvis is the most important investigation. We specifically ask for certain pointers. Importantly, the endometrial thickness. It is given in millimeters. So any endometrial thickness which is more than 1 mm before 8 years is abnormal. The endometrial thickness, once it reaches to 4.5 or 5 millimeter, that indicates the imminent menstruation. So it gives us a lot of information that whether the child is in puberty, depending upon the size of uterus, ovarian volume, and it also tells us that probably how long or maybe how soon we can anticipate the menarche. So very important investigation.
MRI, to do or not to do? It is a female with a central precocious puberty.
In this case, if she's 7.5, not needed. Any girl who is getting the onset of puberty before 6th birthday, MRI is indicated, or any boy who is having a central precocious puberty, one must do. So MRI is for all boys, females, if it is only the onset is before 6 years of age.
So very important, all boys with central precocious puberty, always an MRI. For a girl, if the onset is before 6 years, always an MRI.
Because 80 to 90% of the
Right.
patients who are girl, they are idiopathic. So there's no need to do the MRI after 6 years.
Okay, all right. So anthropometry wise, this child is 126 centimeters, weight is 28.8 kgs. The midparental height is 155. She has mild acne. That's the SMR staging. There is no goiter. This is the growth chart. Dr. Prashant, quickly you tell me your inputs on this growth chart.
Yeah, so we have 5-year reading of height and weight. Primarily, if you see the height percentile, I think she was on 10th, the second line, and now she has reached almost 5th line. So obviously, there's a jump of 2 percentile, and this is a very classic features. So often, parents feel that it is absolutely normal, reassuring, but once we do the bone age, we come to know that it is quite advanced. So this particular jump tells me that there is abnormal growth spurt.
Absolutely. So this jump in 2 centile lines. This is the bone age X-ray with the bone age given, and hormonal tests which were done. Dr. Prashant, would you like to?
Yeah. So in this scenario, we just did the GnRH stimulation test, but even basal LH is quite confirmatory of central precocious
So
puberty.
could we have not done the GnRH stimulation test for her?
Yes.
Okay.
Yes. Okay. And if there is increment of more than 2 or 3 times than that of the basal LH, when your basal LH is less than 0.4, then we do it. And if there is an increment of 3 to 4 times in post-stimulated LH and FSH, that indicates a central source of precocious puberty.
Absolutely.
And any value of estrogen or estradiol which is beyond 20 picogram indicates a onset of puberty.
Onset of puberty. Right.
So this is central precocious puberty.
So we are dealing with a central precocious puberty. Now, how will we treat this girl? Now, I think as a pediatrician or even as a pediatric endocrinologist, I think the goal of therapy here is that the child should grow to a normal adult height. And the second goal is, of course, the parents will be psychologically stressed since the puberty has started early, the prospect of early menses, which can be really distressing to a young girl. So treatment of choice here, Dr. Prashant, and how does this help?
So GnRH analog has been treatment of choice. It's basically a competitive inhibitor. It acts on a GnRH receptor initially it stimulates your LH and FSH, and ultimately it leads to a down regulation of both LH and FSH receptors, so that the LH and FSH as well as estradiol, it is down regulated, and it gives you more time for the bone maturation and epiphyseal fusion. By doing that, it helps you to maintain your first goal, that is to achieve the normal adult height. Here, I would like to stress the point that most of the times we get a referral from the precocious puberty when they get the menarche. Now, the important thing is the GnRH analog will definitely give you an added height advantage if the child is referred early before menarche. Now, if the girl is already menstruating and primarily her bone age is in and around 12 years of age, now even if we give GnRH analog, it is only going to postpone her periods so that she attain the second goal of yours, which you said, that she will be able to achieve at that age where she can handle the periods. But in terms of height increment, I think we lost the battle.
Height is already compromised.
Yes,
in
so
that
primary,
case.
the referral has to be early, ideally before the menarche.
So early referral here is very, very important. How long do we give the treatment?
So it is again subjective. It depends on how much is the height potential, how further are we from the mid-parental centiles. Generally, we treat it at around 10.5 to 11 years of age. Also, when there is a potential to grow. So for a girl child, bone age around 13 to 14 years is still we treat. But after 12 years, we tell the parents that, primarily this treatment is to prolong her periods rather than increasing the height potential.
Absolutely. So, madam, I just want to ask you, so now as pediatricians, when should we refer if we are suspecting this child might be having precocious puberty?
So, the guidelines, meaning any child, girl child less than 8 years of age, any boy less than 9 years of age has secondary sexual characteristics coming up, is indeed a referral point. Or if we are monitoring a growth chart, suddenly if you find a growth spurt. Recently, I was very, very happy there was a referral just about yesterday where the reference was for a change in height centile line. I was really surprised as to how that pediatrician could mark that on the growth chart and refer. Indeed, that child had pseudosexual precocious puberty as part of CH. So whenever the centile lines cross two centile lines, that's a warning sign.
Right.
Like Prashant said, parents might be happy that my child is growing tall, but there must be an underlying reason. Neither growing tall or not growing is normal. So we need to be looking at them. SGA children have a larger propensity to have an early puberty and hence should be monitored. Any girl child who comes with menarche
who's achieved
less
menarche
than
already.
10 years of age would be a candidate for evaluation.
So I think as pediatricians, very important to plot on growth charts and use growth charts in our daily practice. Okay, moving on, we have our fourth case now. This is a 2-year, 3-month-old girl who has prominence of both breasts since the last 2 months. There is no further progression, no obvious growth spurt. On examination, she is 85 centimeters, weight of 12 kgs. This is her SMR. Madam, I would just like you to tell all of us whether is this precocious puberty?
No, this is something called premature thelarche or isolated thelarche, which is physiological. But having said that, like in all parts of our pediatrics, physiology sometimes overlaps pathology. So we need to be able to differentiate, is this girl going to be a pathological early onset of puberty or precocious puberty? Like Prashant maintained it very nicely. Look for eye signs, searching nystagmus. When you're coming for an evaluation, look for nystagmus. Look for cafeoles. Does she have any cafeole, any bony deformities, any other features of sudden excess weight, for example, sudden increase in weight along with these features, should be a red flag sign for you to go further. Otherwise, you could just wait and watch and see how this progression happens.
Right. So this girl's biochemistry, LH was less than 0.1, estradiol was less than 10. Radiology was, bone age was 2 years and 6 months for a chronological age of 2 years, 3 months. So this was a premature thelarche. Yeah. So we can just reassure the parents.
Reassure, but one more thing, no, there have been instances where if she's still a breastfed baby or you have a younger baby who's breastfed and mothers are on, say, the oral contraceptive pills or something, where you have a breast milk transfer of those hormones, where you can have a waxing waning picture. So need to identify, but by and large, this case, you need to monitor.
Okay, so most important, I think normal bone age, normal height velocity rules out precocious puberty per se, more like a premature thelarche. Okay, So now we have a 7-year-old boy with autistic spectrum disorder. Presenting complaint is early development of pubic hair. On examination, there is a growth spurt. This is the growth chart. Testicular volumes are 2 ml and 4 ml with a P2, A plus and gonads 3. So Dr. Alok, I want you to interpret this case.
Yeah, so we've already been through the process of evaluation in the last 2 cases. Here, would you suspect puberty, or is this just isolated adrenarche? Very likely dealing with puberty because you clearly have a growth spurt even in history, and on the growth chart also, if you analyze it, the child is tall for the MPH along with a history of growth spurt. So you would carefully want to investigate whether this is puberty or not. On examination, you have pubic hair, you have axillary hair, you have a penile length which is more, but something is very strange here. You would want to look for the source of androgen, but the testicular volumes are 2 ml and 4 ml. Okay, so you would want to ask yourself, what is the source of androgen here? So going on to the next slide. It's a 7-year-old boy who's tall for MPH with a growth spurt, pubic hair, and enlarged phallus for age. Testicular volumes are small but also unequal. One is 2 ml and one is 4 ml. Next, we did a bone age which is 13 years for a 7-year-old, significantly advanced. A testosterone is 138 for a testicular volume of only 2 and 4 is highly unusual. The LH was undetectable. You have an elevated testosterone, an undetectable LH. You could have an undetectable LH even in true puberty because the initial LH frequencies are less and the amplitudes are also less. So you could possibly do a stimulation test here, but in a setting where we have an unequal sized testis, I would definitely look at the imaging. I would want to do an ultrasound here.
So any thoughts what this could be from the audience? Anyone from the audience? Anybody wants to comment?
Let's see the ultrasound.
So a USG scrotum was advised here, and this is what it turned out to be.
So you see a clear-cut circumscribed lesion with increased vascularity in one of the testes. This was a Leydig cell tumor. The child underwent inguinal orchiectomy. We mentioned, that's a very nice picture of the cut section of the tumor there. We mentioned the child had autism spectrum disorder. That is particularly mentioned because the child had significant hyperactivity. And after the testes was removed, the child drastically improved, although there is autism, but the hyperactivity quotient definitely came down with it. Now, what is very interesting here is because the bone age is already 13 years, the child eventually develops central onset of puberty because your body feels like a 13-year-old and your HPG axis, hypothalamus pituitary gonadal axis, starts getting activated. So eventually this child will require GNRS therapy as well.
All right, so unequal testis, sudden growth spurt, very important pointers here in the clinical case scenario. Moving on to our next case, here we have a 10-year, 4-month-old boy. This child is having poor height gain since 6 years of age. There are no chronic systemic illness, no weight loss, drug intake. Birth history, he's a 34-weeker with a birth weight of 1.3 kg. Weight currently is 17 kg and height is 110 centimeters. Dr. Prashant?
So looks quite short for a 10-year, definitely is a short case. Importantly, with the birth history, is a premature with birth weight of less than 2 kg. So probably we are looking at a growth failure in SGA.
Right. So the mid-parental height here is 167 centimeters. So we managed to get a few height records from this child's school. And this is what the growth chart looks like. And that is the bone edge picture. Dr. Prashant, do you want to comment on the growth chart?
Yeah, so you can see from the growth chart that child is already below 3rd percentile, right from the age group of around 5.5 to 6 years of age. So actually he's amenable for the treatment right at that age. Probably could have started the treatment there and there itself.
Right. So
bone age of 1 point of caution in SGA, that probably bone age is not a good indicator in terms of assessing and calculating the final adult height, specifically in SGA, and the other condition being, skeletal.
So here the child is not only short, but as the child is growing, we see he is much deviated from the 3rd centile.
Yes.
So again, the importance of growth charts here and taking regular anthropometry. So now just quick questions. Are there features that suggest this is the normal variant of short stature?
No,
This child is
definitely a
absolutely very
pathological
short.
stature.
Yes, so this is a pathological short stature. Any features suggesting underlying systemic disease, genetic, endocrine? How do we
So,
rule out?
on your growth chart, if your weight is affected more as compared to height, then probably you're looking at a GI or any systemic illness or anemia.
Right.
Whereas if you have an endocrine or a syndromic short stature, your height point is affected way more than your weight point. So that's based on the primarily on the growth chart. For a physiological short stature or a normal variant, your growth velocity is absolutely maintained, and you're almost fishing in and around at third percentile. So
Right.
which is not the case in our scenario. So this
Of
is
course, the child
definitely
is way below the third centile here. So these were the labs which were sent. The systemic screen was normal. These are the thyroid function test, vitamin D3 levels, IGF-1 which is low, cortisol level which is 10.8 microgram per DL, and a bone age of 7.3 years.
Yeah, so definitely it's a SGA with failure to catch up. All the preliminary investigations are normal.
Right. So this is the SGA child with a failure to catch up. Now why SGA is such a big issue? Sudhara madam?
In a big issue in terms of Dr. Upendra's talk, looking at the newborn care, the antenatal care, the maternal care, etc. In relation to endocrine, it leaves lots of whatever adaptation happening in utero going into some kind of disadaptation. So in the postnatal life. So in relation to endocrine, short stature is very common in these children, and we know that as many as 15% of them do not catch up
Right.
by as late as 4 years of age. And they are often primordial. They have inherent genetic causes for not growing in utero. So those reflect as syndromes, those reflect as primordial dwarfism
Right.
later on in life. And they are set points in terms of adrenarche, early onset of puberty, and metabolic syndromes, which are more common in these children.
Right.
So adrenarche can push the bone age, and they may end up being short if not picked up. So as a person who's dealing with SGAs, it's not just the immediate 1 year of care. I guess these children should get followed up every birthday for appropriateness of the growth chart. Around 5 to 6 years for emerging any adrenarche. Look into the armpit, see for any hair there. And early onset of puberty. By 6 to 8 years, they may have an early onset of puberty. And of course, giving support in terms of optimizing growth by growth hormone.
Right.
So it's not only about height, it's about the whole metabolic issue which these babies face.
Right, right. So we know growth hormone helps in SGA. Dr. Prashant, what is the best time? I'm sure this child was delayed to start growth hormone because it was picked up late. So what is the best time to initiate, and how long do we give growth hormone in SGA babies?
So as per the recommendations, the growth hormone is approved, FDA approved indication since 2001. So we have more than 20 years of experience in treating SGA. The ideal age is roughly 3 to 4 years as per European guidelines.
Okay.
As per US FDA, they start treating these individuals, those who fail to catch up, right at 2 years of age. So across the globe, the age of referral for SGA for starting them on a growth hormone is somewhere around 7 to 8 years. So across the globe, there is some sort of inertia. However,
Right.
if we start them early, it is financially more viable for the parents also, because the weight, the dose of growth hormone is weight dependent. So probably they get a
Right.
higher spurt, and earlier you start, better is the response.
So
as far as
earlier-
how long you treat is, ideally till they have potential to grow, and that means
should.
anywhere in and around bone age of 14 years in girls and 15 to 16 in boys. But practically maybe 4 to 5 years will also give them a good standard deviation spot, which is on an average 1.5 to 1.7 SD score, so roughly 12 to 15 centimeters in final height.
That's quite significant. Okay, so this child was started on growth hormone, and this is what we saw after growth hormone therapy was given. So we have a few spotters now. I know last 5 minutes are left. Last 4 minutes. I'll finish on time. Okay, so madam, we attended a labor call and noticed this post-birth. What should I do now as a pediatrician?
Do not examine the child thoroughly, palpate for gonads. If gonads are not palpable, do not declare the sex. Call for a multidisciplinary care, because you are short of time.
Right. Okay, so a few important take home. Of course, I wanted to know what we do as a pediatrician in the labor room. So do not declare
yes,
the sex,
one
palpate for
thing-
gonads.
Yeah, so do not declare this because though you're looking at a big phallic kind of structure there,
Right.
do not declare this as a male for one. Two is, do not miss on any life-threatening DSDs.
Right.
This pigmentation itself tells you there is possibility of underlying
Adrenal.
adrenal issue here. So keep the child in the unit, maybe do the screening for CAH, and also monitor the electrolytes if there is, if it's there, yeah.
Absolutely.
So
Okay.
don't declare and send home.
Right. Dr. Alok, 15-year-old boy, 50 kgs weight, 125 centimeter height, BMI of 32, has cognitive impairment, has a calf hypertrophy. How do we approach?
Yeah, so you look at the growth chart, you're seeing a short child who's obese. So short and obese, think of endocrine first, think of us also. So, short and obese, you're looking at calf hypertrophy, pseudo-hypertrophy. First thing I would think of is doing a TSH and a free T4 here. Very likely long-standing severe hypothyroidism. So Cocker-Degree Semmelin syndrome.
Cocker-Degree syndrome looks like. Okay. Dr. Prashant, child presenting with wrist widening with the following features. Quickly, investigations and management.
So calcium, phosphorus, most importantly alkaline phosphatase, initial, and vitamin D and baseline creat would be sufficient. As far as management is concerned, I think 3,000 international unit per day or 60,000 as per current guidelines, once in 2 weekly for 3 months. That's the standard treatment as per newer IAP recommendations.
Okay.
So 60,000 instead of once a week, once in 14 days.
Okay, so 60,000 units once in 14 days now.
Once in 14 days, and calcium you can give 50 to 75 milligram per kg.
Okay.
Can I
Madam,
give
you
a
want to add?
perspective? Kindly come for the oral presentation tomorrow morning on daily versus weekly vitamin D and see what's the evidence. Yeah.
Okay, all right. This is 2 years, 8 months, weight is 14.8 kgs, height is 82 centimeter, weight for height is more than the 99th centile. This child had failure to thrive in early infancy, poor feeding, developmental delay. Child now noticed to have increased hunger after 2 years of age with onset of obesity. Dr. Alok.
Any answers in the audience?
Any answer?
Very obviously Prader.
Very obvious case,
so, beginning with failure to thrive in the infancy due to poor feeding, poor muscular tone, followed by increased hunger usually after the 4-year mark, but here it's pretty early. Hypogonadism suggested by the micropenis and the undescended testis, poorly formed scrotal sac, almond-shaped eyes that you're seeing there, and again, a short child with obesity. So,
absolutely. So this is a Prader-Willi, and I believe this is the last slide. So I have finished 40 seconds before time. Thank you.
Very well done.
So that was pediatric endocrinology in a nutshell. It's a huge subject by itself. To take up all the hormones was little difficult, but of course I think we dealt with what we as general pediatricians see in our day-to-day practice, like short stature, like precocious puberty, and that we should not miss congenital hypothyroidism ever. So I really thank my panelists for all the help and for having such a wonderful discussion here today. Thank you so much.
Thanks for the very insightful session and practical ways to approach the patient, how to approach and when to refer, of course. So